Hey everybody, welcome back to the ECG channel. My name is Reed, and don't forget that you can download the PDF of today's ECG document down in the description below so you can follow along and make your own notes. And don't forget to subscribe to the channel if you enjoy this content. So let's go ahead and get started. And so the first thing we're going to do with this ECG is we're going to look at the forest and get an idea of what we think is going on. And so I pick a lead, and as you can tell, some of these QRSs are kind of tall and they're blending in together, but we'll choose maybe V5. And so we've got a narrow complex rhythm that seems to be kind of beating along at a pretty regular interval. My rate, if you notice, maybe we'll find one here that lands on a solid line. So maybe this one, we measure 300, 150, 100, maybe right around 75 beats per minute. Okay. And so they're narrow complex rhythms, so that makes me think that they're coming from the AV node down the Hits-Purkinje system, and I glance in front of my QRSs, and I do see that there appears to be some atrial activity before. So that makes me think that there's some type of atrial activity that is driving this rhythm, but let's evaluate the morphology of the P waves. First thing I notice is that when I look at what the atria is doing, I notice that the P waves in my inferior leads, which are leads 2, 3, and AVF, if you look at the P wave in these leads, they're all negative. That tells me that they're going away from leads 2, 3, and AVF. And remember, 2, 3, AVF, if my P wave is spreading away from all three of those, it has to be spreading from low to high, right? And when would that happen? When would you be spreading from low to high? You would likely be spreading from low to high, especially in the case of a P wave that comes before QRS, with a ectopic rhythm, right, where there's some ectopic focus that fires off and spreads throughout the atria from low to high. And that creates negative forces as those forces are going away from leads 2, 3, and AVF. So we've got something that is ectopic atrial rhythm. So that's our first finding. But we know that after that P wave, we should have a PR interval that is representing how our AV node handles that P wave and sends it down to the QRS. And so I look at my PR interval, and maybe I look here, and I see that the PR interval is in between 120 to 200 milliseconds, or 3 to 5 small boxes, which is normal. And if you look throughout the entire strip, every P wave conducts to a QRS in the same fashion, right? And I even look in between QRS complexes to make sure that we don't have any extra P waves, which I don't see. Now let's evaluate our QRS complex. We said it was narrow, right? If I measured the width of our QRS complex, you would see that my QRS width is less than 120 milliseconds, or less than 3 small boxes. My QRS axis, if I zoom in up here to lead 1, it's upright in lead 1. In AVF, it's also upright in AVF. So it tells me that my QRS axis is going down and to the left, which is normal. It's a normal axis. And you see I've got septal R waves that grow and become dominant in V3 and stay dominant in V5, V6. And you know, what pops off the screen probably to all you guys is just how tall these QRS complexes are. They're pretty tall, right? And that makes you think, is this left ventricular hypertrophy? And so I look, and I know that if I add the S wave in V1, so here's my baseline, here's my S wave. If I add the S wave in V1, which looks to be 5, 10, maybe 12 millimeters is my S wave. And if I add that to the R wave in V5, so the R wave begins here at the baseline, and if you can see, it comes up to right there. We've got 5, 10, 15, 20, 25, we'll say 29 millimeters. And if we add those together, we get a total voltage of 41 millimeters. And we know that we need at least 35 millimeters to call this left ventricular hypertrophy. So we have left ventricular hypertrophy, which makes sense. And so now that we've figured that out, it's our responsibility to kind of work through some of the changes that we expect after seeing a left ventricular hypertrophy. But first, real quick, let's look at our QT interval. I noticed that if I go in between my two QRS complexes, my T waves have terminated by the midpoint. So we have normal QT interval. And so the last thing we need to do is we need to evaluate this ECG for pathological Q waves or ST or T wave changes throughout. Okay. And I want you to remember one thing from this video, that left ventricular hypertrophy has something called ST strain. ST strain means that in the leads that most capture the left ventricular hypertrophy, you'll oftentimes see that your QRS will be this upright QRS, and instead of having this normal T wave after, strain pattern will be something like this, where you have your QRS, and then you have this like ST depression with an inverted T wave. It's usually kind of like this strain pattern. You'll see it often in hypertrophy. And something that I noticed when I look through is that I don't have the typical strain pattern. I've actually got some ST elevations here, right? If you look, my ST segments are actually elevated in my inferior leads, right? Leads 2, 3, and AVF, we actually have ST elevation. We also have just a little bit of elevation here in V5, V6. So you wonder, is this like an inferolateral infarct? Is this an inferolateral STEMI? Well, something else muddies this photo, this picture, okay? I want you to remember something else. There's something called Emery phenomenon. And so the understanding of what Emery phenomenon is if you remember, we don't have evidence of atrial repolarization on an ECG. Well, why is that? Well, that's because atrial repolarization occurs pretty much right on the QRS in the early ST segment. And so because of that, you don't see it because it's usually kind of blended in with that. However, an Emery phenomenon is a occurrence where you can sometimes have what we would call atrial T waves, or T little a, atrial T waves that are more prominent in the inferior leads, and they're more prominent in the inferior leads with ectopic atrial rhythms, right? And so we think of like ectopic atrial rhythms, right? We said that these were like negative P waves in the inferior leads, right? So that would make sense that we would, because those P waves are the most prominent in those inferior leads, we would have the most potential to have a prominent atrial T wave, right? And if you could imagine, the atrial T wave would be occurring like right around there, right? It'd be occurring right around here. And so because of that, you can actually have some artificial ST elevation. But this is like atrial T waves, right? So this ST elevation isn't from ischemia. And so when you look at this rhythm, you're like, well, is some of the ST segment elevation in the inferolateral leads because of Emery phenomenon? Also, what is the contribution of this left ventricular hypertrophy strain? So this is an incredibly difficult ECG to assess for ischemia. And I would say that if you were to assess for ischemia in this patient, you would need to really utilize the clinical picture, right? If this is a young 18-year-old athlete, maybe you're thinking this person has like a hypertrophic cardiomyopathy type picture with the hypertrophy. But if this was a 75-year-old lady with atypical chest pain. She was diaphoretic, maybe a little bit nauseous. She had a smoking history and type 2 diabetes, right? All the vascular risk factors. And you might be wondering, I'm going to lean a little bit more towards acute coronary syndrome. And so this patient fell in that bucket. They were older, they had risk factors. Some of their previous ECGs might have had a little bit of subtle changes compared to this, so maybe we were thinking there were some new changes. It was really difficult. We actually took them to the cath lab, and they had a occlusion of the right coronary artery, which kind of ties in well with this mostly inferior STEMI with a little bit of low lateral involvement with V5 and V6. And so that's what we found. And so when we put this ECG together, we have an ectopic atrial rhythm at a rate of 75 beats per minute. And then we had this evidence of left ventricular hypertrophy and some infralateral STEMI changes. Right. And so a couple things I want you to take out of this video is left ventricular hypertrophy and Emery phenomenon. Not too many people know about it, but go read about it. And, it's interesting to just have that in the back of your mind of how much is this contributing to these ST segments in the inferior leads during an ectopic atrial rhythm, right? So hope this helps. And if you have any questions, put them down in the comments. And if not, thank you so much for watching. Have a great rest of your day. We'll see you on the next ECG video. Take care.